All righty. Everyone ready? All right. Well, good afternoon, everyone. My name is Jovonni Spinner, and I will be moderating your panel today, Securing the Cancer Continuum of Care Model for Racially and Ethnically Diverse and Medically Underserved Population. I am very pleased to be here with this distinguished panel of women to my left who represent multiple sectors across the cancer continuum. But before I introduce our panel members, let me provide you a little bit of background about why we're having this panel today. So, cancer affects people of all races and ethnicities in the United States, but what we do know is that the burden is greater for certain groups. Differences have been observed among some racial and ethnic minority groups related to the incidence, screening, cancer-related health complications, and stage of diagnosis. For example, behavioral risk factors for cancer, which I'm pretty sure you all are all familiar with, are smoking, physical inactivity, obesity, excessive alcohol intake, among others. Most of these issues disproportionately impact racial and ethnic minority groups, which leads to a higher incidence rate of cancers among these groups. Now, what we've heard across all of the panels today, I think the common theme has been the social determinants of health. Cancer is no stranger to that, as well as the social determinants of health do have a significant impact across the care continuum. The social determinants of health, like access to care, transportation, access to healthy food options, among other issues, definitely impact cancer care and treatment. But despite making strides in cancer care, many barriers remain for patients diagnosed with cancer to receive excellent care. The framework for our conversation today is going to be guided by the 2013 IOM report, which is now the National Academies of Sciences, Engineering, and Medicine. They published a report entitled Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis. This report outlines several themes that can be addressed to improve cancer care across the continuum, ranging from prevention, screening, diagnosis, treatment, survivorship, and end-of-life care. So during this session today, the panelists will share their notable practices along the Cancer Continuum of Care framework that will ultimately improve cancer-related health outcomes for diverse and medically underserved populations. Now let me introduce our panelists, who will then provide a brief 5-minute overview of their work before moving into the Q&A portion of the discussion. Please keep in mind that their full bios are in the program today. First, we have Captain Richardae Araojo. She's the Associate Commissioner for Minority Health at the Food and Drug Administration. We also have Patricia Doykos, who is the Director at Bristol Myers Squibb Foundation. We have Andrea Ferris, who is the CEO at Longevity, Claire Saxton, Senior Director of Education and Outreach at Cancer Support System, and Lori Wilson, a Surgical Oncology Chief at Howard University. So now I'm going to start with Captain Araojo and provide your opening remarks.
Thank you, Jovonni. Thank you, Jovonni. Good afternoon, everyone. It is a pleasure to be here with all of you this afternoon. A little bit of feedback, all of you this afternoon, and especially to serve on this panel. As Jovonni mentioned, I am the Director for FDA's Office of Minority Health and Health Equity, and really excited to be with you. Just to kind of back up and provide a little bit of information about the FDA, as many of you may be aware, the FDA is responsible for protecting public health by ensuring the safety, efficacy, and security of the various products that we regulate, and we regulate quite a few products. And I think that's really important because when we think about FDA, we always think about being a regulatory agency. And I think it's really important for us to also remember that we're also a consumer protection agency. And when we think about that, that of course brings to mind the Office of Minority Health and Health Equity and the work that we do. We work to support FDA's mission by protecting and promoting the health of diverse populations through focusing our efforts on research and outreach and communication that addresses health disparities. So within research, we're really focused on advancing minority health-focused research, trying to increase data that's available on racial and ethnic minority populations. And when we think about outreach and communication, we are really focused on trying to improve FDA's communication with racial and ethnic minority populations. And we do that by developing both culturally and linguistically competent information and materials so that we can raise awareness around FDA's efforts. So we work across the agency. We also work very closely with public and private sector stakeholders. And when we try to raise awareness around FDA's efforts, one of those key efforts and central to the Office of Minority Health is trying to increase diverse representation in clinical trials. So I think when we talk about the cancer continuum of care, what's critical to that conversation is trying to continue to advance diverse representation in all trials for products or diseases or conditions that disproportionately impact racial and ethnic minority populations, and especially cancer clinical trials. Thank you.
So next we'll hear from Claire.
Great, good afternoon. My name is Claire Saxton. I'm the Senior Director of Education and Outreach for Cancer Support Community. Cancer Support Community is the largest professionally led network of cancer support worldwide. We have 50 affiliates. We have 9 hospital and healthcare partners. And we have about 125 satellite locations where cancer support community services are provided. And so the services provide, can you still hear me? Okay. Individual counseling and support groups that are offered by licensed mental health counselors. We have some services that mirror patient navigation, like patient education, information, and referrals to help meet the practical needs of patients and their loved ones. We also do distress screening for social and emotional health cancer patients and their loved ones who are acting as caregivers to help identify the barriers that keep them from accessing, complying with, and staying with treatment and follow-up. So together with our information and services available on the web, our patient education, our helpline, and those local centers, we touch about 1 million people each year. Tying this back to the healthcare continuum of care that was mentioned at the beginning, CSC provides most of its reach to cancer patients and their loved ones, starting from the diagnosis phase through treatment, whether that be through clinical trial or not, and also survivorship. So those are kind of the main points where we touch patients and caregivers. And when we look at the patients that we serve and the caregivers that we serve, we know that we could do better at reaching diverse populations. And so at the Cancer Support Community, we have several initiatives that we're working on to improve our diversity and inclusion. We're in the process of developing a diversity initiative steering committee through our organization to help us better diversify and increase both the cultural competence and cultural humility of our board, our staff, and our programming, as well as through taking it through to our psychosocial oncology research that our Research and Training Institute does. In terms of working to make our services more accessible to the full diversity of cancer patients affected by cancer, we do things already like translating and culturally adapting educational materials by having bilingual helpline professionals and using a translation service so that we can talk to people in 200 languages through our helpline. But what I really want to talk about are 2 large initiatives that we're currently undertaking. We are working with the Navajo Nation care to the Navajo Reservation. When Tuba City Regional Healthcare Corporation starts delivering the first ever full-time cancer treatment offered on a Native American reservation in Navajo Nation this month, Cancer Support can partner with them to provide culturally appropriate, Cancer Support Community will partner with them to provide culturally appropriate psychosocial support and information, in addition to the infusion services that are going to be offered on the reservation. In working with this Navajo-led healthcare institution to create these services, and culturally adapt our model for providing services. We're doing all kinds of things that really get to both the Navajo culture and traditional healing beliefs, as well as to the practical concerns of people who live on a reservation that spans 3 states, has between 15 and 30% of the population who have no electricity or indoor plumbing, and see stomach, gastrointestinal, liver, and gallbladder cancers at rates 2 times and more higher than the white population in the area. So some of the things that we're doing are adapting our distress screening tool to the Navajo culture. It means asking about things like the availability of clean water in your home and the availability of firewood for heat. As well as gas for transportation across long rural distances that can be real barriers for people getting treatment, and has meant that some people decide not to get treatment. So the other big initiative that we're working on at Cancer Support Community is to open an in-person cancer support community affiliate to serve those affected by cancer in the National Capital Region by 2020. And we're committed to having an affiliate that reflects the diversity of the Capital Region and can deliver the culturally competent care that people in the Washington, D.C. area need. And that starts with listening to those on the ground so that we can add to the capacity of the network of groups we're engaging that already engage with area residents. And so we're in the process of developing a community engagement council to look for leaders who have knowledge about working with these patients already, and how can we add the additional support services that our model offers to these patients. And so I'll just kind of wrap up there. That's Cancer Support Community and our current initiatives on diversity and inclusion and reaching minority populations.
Thank you. So next we'll hear from Andrea.
Hi, I'm Andrea Ferris. I'm the President and CEO of Longevity Foundation. We are the nation's largest lung cancer-specific patient advocacy group. For those of you who don't know much about lung cancer, it's actually 30% of cancer deaths in the country are attributable to lung cancer. It actually doesn't discriminate on incidence, but there are huge differences in outcomes for the patient populations. The other interesting thing with lung cancer right now is scientifically it has just gone under a complete transformation. There have been more drugs approved by the FDA in the last 3 years than in the prior 3 decades. So people are now living with the disease very differently than they had before, and we have an opportunity to use it as a case study to change a lot of policy, the way that healthcare is delivered, the way that things are covered and reimbursed, clinical trials and things like that. So at Longevity, with respect to underserved populations and minority or diverse populations as well, there are really kind of 2 levels of things that we do. One is the work that we do individually. We have a patient-focused research center where we did a big patient preference study. We're launching a big longitudinal study to understand how people are living with the disease, but that includes accessing care. It includes how they are, some of the PROs or psychosocial elements to it. And with all that we do, we are always sure to partner with other organizations or to try to engage so that we can have a diverse respondent. Most of the people who come to patient advocacy groups are not underserved for the most part, and that's sort of at large, across all of the groups. And what we're really trying to do is to reach beyond the engaged population. To make sure that we can also include and get data and information on the unengaged, if you will. A lot of that work goes through specialty pharmacists, and that was interesting with the Walmart example, because that's actually something we're working on with respect to screening. For us, it goes the whole spectrum. So there's sort of the pre-diagnosed patient, which is how do we get more people into screening? Can we use a pharmacist to trigger some of that? Many people don't have a primary care physician or don't go to them, so they don't know to get a script to get a scan. creating screening adherence tools. So once somebody has been screened, how do you keep them coming back so that they are found early and actually stage shift the disease that way? All the way through diagnosis, how are they accessing their care? We just finished a big study with Cancer Care on financial toxicity, looking at their population, which is more underserved than ours, and to see if there are different interventions that are needed there. All the way through to survivorship as well, and making sure that we have programs that satisfy the needs of all, working in the community setting as well as in academic centers, because 80% of our population is treated in a community setting by non-specialists. So that for us is very important to do. I think the more important work that will, well, not everything's important, but really the things that can help change things at a larger level are more the systems and multi-stakeholder type initiatives that we've been working on with Jeannie and her group in terms of clinical trials and other industry partners on inclusiveness and research, as well as with the FDA to revise eligibility criteria, to create decentralized clinical trials. How can we try to get more trials out to where the person is rather than have everybody travel? That was one of the things out of the financial toxicity, that travel to care is actually one of the biggest issues. We're also launching a national report card where we can go state by state to see where there are comprehensive cancer centers, where the Medicaid population is covered for screening or for biomarker testing, which in our disease is hugely important because it's really at the forefront of precision medicine. But if you don't have access to the test, you don't know what treatment to get. And a number of other parameters as well, which will help then inform the policy work that we do to ensure that all people can access optimal care. We've also been working with the Association of Community Cancer Centers to create an optimal model for delivery of optimal care to the Medicaid population, which is hugely important. And similarly with the clinical trials, with the work that we did with Jeannie and the Sustainable Healthy Living community is on creating those models and case studies of clinics or centers where they are able to enroll in the clinical trials on a broader basis as well. So I'll wrap it up there. Happy to answer any questions, but just so that we have time for conversation.
Thank you. So next we'll have Patricia.
I'm so pleased to be here. Thank you so much for including me. I'm with the Bristol Myers Squibb Foundation, which is an independent charity, nonprofit, and our mission is to promote health equity and to improve outcomes of disproportionately affected populations. And we have a global cancer disparities initiative spanning Asia, the United States, and Africa. I primarily work on our projects here in the US as well as in sub-Saharan Africa. And we are big partners with the lung cancer disparities work here in the States. We have an initiative called Bridging Cancer Care, which focused on the tobacco belt in terms of standing up these lung cancer screening programs for the first time, and then survivorship. It's a new day there, so also looking at that. And then the program I lead, Specialty Care for Vulnerable Populations, looked at all cancers. Really, we wanted to leave that open so that communities could tell us, we want to work on breast, we want to work on prostate, colorectal, Asian American, Native Hawaiian, Pacific Islander, looking more at gastric cancers and so on. And then in Africa, we work on women's cancers, pediatric cancer, cancers for affecting HIV populations as well. And across all of these programs, the common approach for us is really addressing barriers inside clinical care, so health system strengthening, whether that's healthcare worker training, looking at workflows, quality improvement projects, things like that. And then we also look at the barriers outside the clinic, so social determinants of health, social determinants of equity, and social justice issues as well. And essentially everything that we support has clinic-community partnerships where clinical care and community supportive services are working together to serve the patient so that they can optimally get through the continuum of care, not just get to screening, but then we lose them before diagnosis. Not after diagnosis and losing them in treatment. So with all of this, we're really affected by the HIV continuum of care and how the whole community in HIV sees themselves responsible for the whole thing because they're looking at the outcomes. That's really whether we know we're doing things well or not. So in the projects that we support, which are really to provide innovators with space and resource and time and people to explore ideas and models of care that will be more responsive to medically underserved populations and change not only the clinical care experience, but most importantly, the outcomes for all of that. And as we work with partners on that, we think from the beginning about sustainability. We don't want it to be an academic exercise that you figured out a better model of care and then it gets published and it doesn't actually stay in the, either the institution that's trying it out or spreading it more broadly across the field. So with our grantees from the beginning, we have them work with Harvard Law School on policy and advocacy work, as well as FSG, which is a consulting firm for social change. And they work with the grantees to start to think about how are you going to talk to the head of your health system to say, we're trying out this model of care. We think it can do a better job for Medicaid patients with lung cancer. We want to try a number of things. How will you be with us at the end if we show that this is an effective model of care? How can resources be moved around? How can this become the way we do things here within our health system? And then, of course, Harvard works from a policy perspective with our grantees too, thinking about what are the enabling policies that need to be put in place, like working with the state of Maine on finally getting through their coverage for low-dose CT scan screening. So all of this is really important to us. And one of the other things that we really emphasize is that there's projects that are implemented, but those are all within institutions that most definitely can improve in how they serve medically underserved populations and how they behave themselves. So where is unconscious bias training in the organization? How are they looking at the populations they're taking care of and seeing, by segmenting the patients, what is the difference in patient experience through the continuum of care? So are Medicaid patients having a different experience? Are racial and ethnic minorities, LGBTQ, just differently abled populations, and really beginning to dig in and see what are the ways that we can improve by segmenting patients in that way. So this is sort of the scope of work. It's a very long process for us, not only the innovative ideas that come forward, but then really seeing it through to how can it stay in place and really transform care for patients and their families as well.
Thank you. And lastly, Lori?
I just want to take an opportunity to thank you for the opportunity to speak to you. I am a boots on the ground kind of gal. I am a cancer surgeon by training. I have lots of hats at Howard University Hospital. Howard University Hospital is a safety net hospital, which means by and large the vast majority of the patients that we serve, though we serve a spectrum, the vast majority are managed by governmental insurances. Our patient population oftentimes don't have a voice. They don't have resources. They don't have an opportunity to understand what their barriers and what their resource opportunities are, and that's where we step in. I'm lucky to wear multiple hats, and let me just take a step back. Why is this so important to me? I'm first generation. I am first generation going to college, first generation going to medical school, first generation being able to step in and actually have an opportunity to be on a panel like this and have a voice for the women that I serve. And for me, this is my dream job. I wanted to come back to Howard. I trained there undergrad and medical school at Georgetown, but came back and did my residency at Howard, my surgical oncology out west, but wanted to come back and be a part of Howard because it meant so much to me. Being able to partner with women and meeting them where they were. It really is about not only understanding what their disease process is, not only understanding what their barriers are, what their resource needs are, but having someone who's going to sit there and actually listen and understand what the next steps, and make sure that they understand what the next steps are. We talk about barriers, and I know that we will have a in-depth discussion, and we all understand them in different ways. I know that what I bring to the table is not only being a cancer surgeon, but also being a program director. Each year I train 32 phenomenal young people to become surgeons who will come back and serve the same community that I serve. They understand the cultural dexterity, they understand the cultural humility, they understand the questions, and hopefully will serve our populations in ways that are sustainable, in ways that allow us to answer questions, not only about how to best serve them in the future and make sure that they're adherent, but also to make sure that we understand what their needs are. Because part of that cultural humility is knowing that they bring a lot to the table and we have to listen. One of the things that I wanted to share, and I told Jovonni, is that I actually am a cancer survivor. I was originally diagnosed in 2013, and I was the breast, if any of you all remember Cancer Emperor of All Malady by Kenneth Burns, I was the breast cancer patient that they followed through. At the time, I had a wonderful diagnosis. All my breast cancer went away, but in January of 2019, it came back. So I am a metastatic breast cancer patient. So I have gone through the continuum. I have met with women across the country. I've talked to patients in every aspect of the care, not only in breast, to talk about what their needs and concerns are. And hopefully I can help to be a voice for that population as well. So in the bigger picture, I have had an opportunity to not only utilize my skill set to help and cure. I've had the opportunity to listen and assess resource needs, understand what the goals and objectives are for my patients, understanding how they may make decisions that are different than what we would probably expect them to make because of the pressures that they have secondary to the social determinants of health that are real for them. I also have had the opportunity to be in the educational sphere so the generations to come will understand the cultural questions, dexterity, humility, and hopefully be able to carry on a gauntlet and help patients understand what their needs are and really serve them. Because service is really at the heart of what we do. And last but not least, I'm hoping that as I go through this journey, which is the cancer that is my lot in life, that I can help to understand what the next steps are for the ways that we look at treating patients with diagnoses and how we hear them and how we feel. And if we are heard, and hopefully when we're heard, that when we come together, there will be something really special that comes out of moments like this. Thank you.
Thank you. So during our remaining time on our panel, I want to dig deeper into every point of care across the care continuum and kind of weave it all together. So when we leave here today, we have a better understanding of what the solutions are at each point of care and how people in the audience can take some of these lessons learned and apply it to their work. So I'll start at the screening point of care and ask you, Andrea. So during the screening phase, what is the role of biomarker testing in improving cancer care in the populations that we have discussed today?
Biomarkers aren't yet in lung cancer screening. Right now, lung cancer screening is defined by the outcomes of a large national study, and you have to fit into a high-risk category, being over 55 years of age, although I think they lowered that to 50, 30-pack years history of smoking. So there are criteria by which then you can get a CT scan. Biomarkers are being developed to be able to risk stratify the population, to understand who should be more vigilantly screened or who should need follow-up more carefully. But right now, the screening is really defined by the criteria from the study.
Okay. And moving on to Claire, could you describe some of the strategies that can be used to improve coordination of care for patients so they progress through the continuum of care? I know you mentioned in your remarks, about the psychosocial support, but, what role do other health professionals play in the continuum of care?
Sure.
throughout moving people throughout the continuum of care, it really is important to focus on establishing trust. Whether you're talking about trusting the recommendations for screening or trusting that when you're diagnosed, there can be resources in place to help you be able to cope with that diagnosis and cope with what those practical concerns can be, both for you and your family, in terms of actually getting treatment. I think that there's a lot of fear out there the moment that you say the word cancer. And even before you say the word cancer, I think there are a lot of our communities that don't like to talk about cancer and don't even talk about their own family histories of cancer. I've known too many cancer survivors who only found out about family members' cancers after they themselves were diagnosed, and the family member then came and talked to them about it. And so, when looking at whether it's public health people helping with promoting screening messages and prevention messages and healthy eating and exercise messages, or it be the nurse practitioner and the medical oncologist or the surgeon who's helping to biopsy or diagnose the patient. I think a lot of what we need to look at in terms of kind of engaging the community is how do we build that trust, and how do we alleviate the fear that's there so that we can have a good conversation and people can feel like they have the information they need to make good decisions for themselves.
Can I just go back?
Yes.
So what I was talking about was lung cancer specific. There are some diseases like breast and others where they do have biomarkers where you're at a higher risk. And if you have that marker, then you should be very vigilant about going and getting screened. I think colon and prostate probably have some borderline ones as well. So from that perspective, I think biomarker testing and having that relationship with a doctor and a relationship of trust to then lead to understanding the importance of what those mean and whether you should be screened can help change health outcomes in terms of finding diseases earlier, which I think is a large part of what we need to do in the cancer continuum in terms of improving outcomes, is really helping the population understand of why it's so important to screen and to be vigilant to find things early. And biomarkers can play a role in other diseases outside of lung cancer.
Thank you. Lori, can you speak to the fact that many patients may not be getting screened and go right to a diagnosis, many of whom may be diagnosed at a late stage? Can you expand on some of the practices that will ensure that these patients will get into treatment?
Sure. We definitely know that there are populations that have not met our screening expectations and then present with a diagnosis. We do know that in some multi-ethnic groups that cancers can be diagnosed at more aggressive stages, at later stages. It's important to not think of it as a silo. We have to think of this as a multidisciplinary approach, that we are here to surround the patient not only with the care team that's necessary, but also with the understanding of what their needs are when they come to the table. I think that we act as though health literacy isn't as big of a deal as it is. We've taken so much out of early education toward health literacy. To bring someone in and expect me as a clinician to spend 30 minutes not only diagnosing, going over materials, examining the patient, and then coming up with a treatment plan, and having that all sort of work out so that they understand what I'm talking about, I think that that's unreasonable. We know that time is a barrier. We have to come to a consensus that we have to make a understandable opportunities for patients to get the information that they need so they can make the best decisions that for themselves. But we have to know that that can't just happen in a 30-minute continuum. I think that some of the information that's necessary is partnerships. We talk about trusting partnerships. One of the things in our practice, every practice is different and every practice should assess what their needs are. Our nurse navigators are essential. They provide a trusting relationship for the patient so that when they walk out the door, they can continue to have the conversation and have those questions answered so that when they come back to us, the nurse navigator understands what really needs to be addressed. We can go on to have a second conversation, and then you can develop programs within the needs for the patient. What we've designed is we understand that the vast majority of our patients are service workers. They don't get time off, they don't get vacation pay, they don't get sick leave, they don't get opportunities to leave their job multiple times without their jobs being in jeopardy. So one of the things that we designed was a multidisciplinary half day so that everyone comes in, they see all of their specialists, palliative care, they see nurse navigator, they see the genetic counselor, they see all of their providers, all on the same time frame, but it's half a day. So that they have hopefully essentially made 5 visits down to a half a day. Hopefully making it a more palatable decision to actually get their diagnostic and therapeutic decisions made, as opposed to say, I just can't take these 5 days off. And then coming to the office, like, well, you haven't done all of that I've asked you to do. We can't really move ahead with a plan yet. And so it really is understanding the needs, assessing your population, and making sure you have those services in place for your patient population that addresses their needs.
Thank you. Yes.
What did you have to do to get that done? I mean, that's amazing, like sort of the administration. So how did you implement that?
So understanding, our cancer director is also boots on the ground kind of gal. Really understands the needs and the purpose of what we're trying to accomplish. And so once we address the sort of the SWOT, the needs of our patient population, we had several in-house meetings, and it was a sell to get everybody on board. But realizing the needs of the patients really outweigh the goals of just getting patients through. Was something that she really saw that was of value, and I really applaud her for her foresight. Yes, yeah. Absolutely.
Okay. So given that you've just described the amount of time that it takes to have all of these visits, I wonder if, Patricia, you could speak to how could technology possibly improve care in the treatment phase, particularly as it relates to using maybe like telemedicine or telehealth, as it relates to maybe rural populations or people who may not have access to getting to a physical site for appointments.
Sure, I'd be happy to. So our biggest work in this area is with Project Echo. I don't know if folks familiar with Project Echo at all? Okay, so it's a telementoring and collaborative care platform. And essentially, it's a hub and spoke model where, particularly at academic medical centers, NCI-designated comprehensive cancer centers, an interdisciplinary team of experts who form the hub then are connected via telehealth with community-based spokes. And this is not just a webinar, let's teach you the latest in NGS or something like that. This is meant to be an ongoing relationship between the hubs and those institutions, as well as, the spokes and the hub institution. And the way this works is that through case-based learning, that the spokes in the community oncology practices or FQHCs as well present cases to the interdisciplinary team and get guidance on how to pursue their care and treatment. So that those folks who are at spoke A also hear then the 2 cases from spoke B and then C and D, and it accelerates their learning from each other because they don't see that many cases. So if they can see the particularities and the nuances of what's happening with all the other cases and get the guided practice, that accelerates their learning. This has been pursued to very great effect in many other therapeutic areas, and then our foundation went to Project ECHO and said, what are you doing in cancer? And they weren't doing very much. So this has really been a big push. And since we started in 2016, over 34 organizations, both cancer centers as well as ACS, the NCI, have been trained, and we're now implementing 63 different programs. So at those 34 centers, sometimes they have multiple programs. So they may have a breast cancer diagnosis program, they may have an NGS program, they may have a survivorship program as well. So this has really been an important way, given the crush of new tools for addressing cancer across the continuum of care, to move that knowledge into the community, into where the disease burden is, as quickly as possible. So it's really essential. Fortunately, from a sustainability perspective, before President Obama left office, the ECHO Act was signed, and HHS was charged with studying it. That study has now come out, and it was a very positive one. There's certainly areas for improvement and for continued research and understanding, but there will be now a Hill Day in the middle of June where programs from 50 states are going to come and speak to their representatives on the Hill about what they're doing with their different programs. So, and just to give you a sense of a couple of the types of programs that exist, MD Anderson has really been the leader in implementing these programs. They have one for cervical cancer diagnosis and detection with FQHCs, and also with community oncology throughout the state of Texas. And they also have a skin cancer and melanoma diagnosis program. They have many others that they do on the global health side of things as well. So that gives you a bit of a sense. And then ACS has undertaken a multi-state Project ECHO program where their hub isn't, they're not a NCI, they're not a clinical center, but they have curated a set of experts from different centers to then provide guidance to 8 different states in the South on lung cancer survivorship. So another way to use this model, but with the crush of knowledge, getting it out there with people who have used the knowledge, directly in touch with folks in the community. And this is also a two-way learning. Definitely the NCI designated comprehensive cancer centers and academic medical centers are learning about the reality of what cancer care looks like in the community as well. And then one last benefit is that now that the institutions are connected, not just for a webinar, but with this ongoing relationship, if a patient in the community truly can only be treated at the academic medical center or NCI Comprehensive Cancer Center, at least that institution now has an eye on those patients, and they can start to work together to make sure that the patient that gets the care and support that they need.
Thank you. And Richardae. So we know when patients get to the treatment phase, many patients may want to look into enrolling into a clinical trial, because we know we definitely need clinical trials to make sure that we get new therapeutic products to the market. Could you describe some of the strategies that are being used to enroll more diverse populations or to raise awareness around the need for diversity in clinical trials?
Sure. We know, of course, that clinical trials provide a crucial base of evidence for evaluating whether a medical product is safe and effective. And for us with the Office of Minority Health, of course, we are very focused on trying to advance diverse representation in clinical trials so that enrollment in the trial really will represent the diversity of the population that will ultimately use that product. So one of the strategies that we've used is developing an ongoing multimedia campaign that's really focused on trying to provide positive reinforcement through education to address some of the barriers preventing racial and ethnic minority populations from participating in clinical trials. With this campaign, we have a variety of strategies that we've used. So for example, we've developed educational materials that are available in both English and Spanish. These are materials where we've really focused on trying to develop culturally and linguistically competent information. In addition, we developed videos, and I have to say that's probably the one area where we get a lot of feedback from our stakeholders. When are you going to develop more videos and more information? Because these are tools where we have actual patients who have participated in clinical research and clinical trials, really highlighting the importance of why they participated in clinical research and why they think it's important for others to participate and learn more. In addition, we also want to make sure that we develop tools and resources to meet the populations we serve at their place of need. So for example, we want to make sure that we do social media outreach. We want to make sure that we have print and digital materials. We want to make sure that in addition to the videos, that we have resources that really will help the populations that we serve. And I will tease Jovonni right now as our lead for our outreach and communication team. We know that that's critically important. And with this campaign, though, I think what's important to think about is that we have these tools, we have these resources, they're freely available, they're on our website, we have them in a nice communication toolkit, but in addition to that, we have to do more. So one of the things that we do is we try to engage communities, we engage healthcare professionals, and we really try to work across, build collaborations and partnerships across academia, industry, with patients, with consumers, with patient advocacy groups, because we know we cannot do this work alone. We develop tools and resources all the time, but there's a lot of work that's ongoing to advance diverse participation in clinical trials so that we can get really good treatments out there for the diverse populations that are going to use those products. But a lot of work is ongoing in silos. So one of the things that we try to do is connect organizations together. We also try to really encourage others to share best practices. So we hear a lot of the successes, and we want to make sure that those successes and what has worked and maybe what hasn't worked, that information is being shared across both researchers, across science, across patients and providers, so that we're all working together to really try to achieve that goal of having broad representation in clinical trials.
Thank you. We are nearing the end of our session, so if there are any questions from the audience, I would encourage you to line up to the different microphones. But while people are gathering, I do want to pose one question to the panelists, because we are very solutions-oriented people here. So could you provide any trainings or other resources that may be available to stakeholders, and think broad? So it could be policy, it could be patient advocates, patients, it could be medical providers, that they could be equipped to adequately address some of the issues related to treatment all the way through survivorship.
I guess one of the things that comes to mind is the programs that there are for training patient navigators, because we see patient navigators, in some cases nurse navigators, in some cases lay navigators, sometimes they're social workers, but really making sure that, because patient navigators can be such an essential part of keeping patients engaged, helping them understand what they should expect, the things that they should make sure that they tell their healthcare team that are going on immediately if they're going on. They really can help keep the conversation going throughout that continuum. And so we certainly encourage all organizations that look at using patient navigators, even lay navigators, to look at the different training programs that there are for them, because that kind of certification and that kind of professionalism of that job means that you have good patient-provider boundaries in place, and really can make a huge difference in patients' lives.
I just want to add that there is a accreditation for many of the cancer centers across the United States. As you may know, that's a Commission on Cancer that sort of credentials them. There are many, and I'm not just advocating this, best practice venues, forums, conferences that allow organizations to come together, learn what best practices are in the community for, especially for protocol-driven, both solid and liquid tumors, and how do you go about managing those patients across the spectrum of care. And it may be an opportunity not only to learn about what the protocols are, how do you initiate and implement them in your own institution, but it also gives you that one-on-one partnership or opportunity to discuss with other local organizations that might be similar to yours. How are you doing it? So you're not reinventing the wheel. I think a lot of what we should be doing is building relationships and building networks.
I think that that's absolutely right in terms of there are a lot of best practices. I mean, Patty, you were talking about some of them as well in terms of people learning from each other and things like that. I think two other things. One, with respect to the clinical trials, but I think we need to remember now too, clinical trials aren't just a research vehicle. Well, they are, but they're not. But they're oftentimes of clinical care, and it's oftentimes the best care. In lung cancer, there are 300 clinical trials that are first line. So it's the first treatment that somebody's going to get is on a clinical trial, and it's usually a biomarker-driven one. But so I think that it's hugely important to educate about clinical trials and about their role now versus 10, 15 years ago, which is completely different than it once was, which is why we advocate for it so strongly, as well as ensure that everybody has access to it, not just for the representation, but really for the access to care. The other component of it is while there are a number of resources available or abilities to share best practices, I think on a more personal level, there are also social networks that for patients where they can interact with other patients to learn what they're doing and where they're going, what are they accessing. I know we have, obviously we have Facebook groups, we maintain 14 private Facebook groups, but we also have peer-to-peer phone buddy. We have a clinical trial ambassador program where if somebody's considering a clinical trial, we'll match them with somebody who's been on one or a similar one. We match people based on age, gender, and stage of diagnosis with others. We match caregivers to caregivers. So these resources exist. I know Cancer Support Community has great resources. So I think that one is at a institution level and at a systems level of what we should be looking at, but I think we shouldn't forget at the individual patient level and caregiver level as well, those resources are out there to avail yourselves of.
And just a couple, first of all, I just want to make sure folks know that if you're interested in Project ECHO and how to learn about the model and adapt it perhaps for your centers, the immersion training is for free. It's a 2-day immersion at the University of New Mexico and also at MD Anderson, which is available on an ongoing basis pretty much every month they do that. There's also a monthly 1-hour webinar. And then the other resource that I would recommend to you, really from a health equity perspective and equity in healthcare delivery, is the Institute for Healthcare Improvements Pursuing Equity Framework, which really looks at both not straight up quality improvement exercises to make sure that the continuum of care is secure and happens equitably for everyone and for everyone, but also, as I was mentioning before, looks at some of the institutional work that needs to be done. First of all, making health equity a priority, stated from the top, from the CEO level, actually putting people and resources behind it, but then also dealing with things like eliminating racism from the organization as well and from the community. And another one is just seeing the center as not just a clinical center, but a backbone organization in the community. So it's not just about what's happening inside those walls, but everybody they employ, all they do with the community, people who work there, live there, really seeing themselves as part of the community and being of service that way as well. So those are two resources I'd recommend.
The other resource is pharmacists.
Pharmacists?
Yeah.
Yeah,
Don't overlook I mean, nurses, nurse navigators, absolutely.
Yeah.
But you got to get somebody to the institution first, and the pharmacist can play a tremendous role in educating.
So we will take a question. In the interest of time, I will ask you to keep it brief into a direct question, please.
I'll do my best. Sage Enda, I'm one of the 40 under 40 honorees, also a tumor immunologist, neurosurgeon scientist at the NIH, studying brain tumors, and also a member of the board of directors of the National Brain Tumor Society. I have several questions. I'm only going to ask one. I'm not going to ask my pipeline question, though I want to ask it. I'm not going to ask my clinical trials question. I'm not going to ask my question about sub-Saharan Africa trials, even though I run an organization that does
Which question
neuroncology
are
in
you
sub-Saharan
going to ask
Africa.
us?
The one I am going to ask is on patient advocacy, because this was brought up, is the lack of diversity in patient advocacy organizations and lack of diversity in the patients that are able to get to patient advocacy organizations. One of the things that the National Brain Tumor Society has recently done is really increase the diversity of the members of the board of directors of the National Brain Tumor Society, which was brought on about by one of the African American members of the board of directors, beating them on the head and saying, go out and get more, which I was one that was brought on. So since the panel is predominantly people that are from patient advocacy organizations, I did want to ask what specifically you're doing to bring people into the leadership in your organizations that are diverse, so that you can continue to increase that outreach, so that it's not just the patients that already have friends and neighbors that have been part of these advocacy organizations, but others that are now getting the benefit of having those navigators and knowing which centers to go to and knowing which surgeon might be better and knowing which trials are out there in the future. Thank you.
I can answer this fairly quickly for cancer support community, because it's a big initiative of ours that we're really gearing up to look at. Because when you look at the research, the patients that we do research on for psychosocial research, when you look at the patients who are able to come through our doors, especially of those freestanding centers, we do see in centers that have bilingual programs, we see a lot more diversity. And in centers where we have satellite locations at the point of care, we see a lot more diversity. But we're also looking and doing a multi-year project with this Diversity Initiative Steering Committee to look at our board, to look at our staff, to really dig in and see what can we do to, it's people who have resources, it's easier for them to get to us. And so we need to figure out, how do we get to those people who don't have the resources and really need us to show up where they are, when they need it, with just the right amount of information, so that we're not completely overwhelming them.
And so for us, it's two pieces. So that on the staff level, I think that we're pretty diverse. On the board level, increasing it. In terms of the programs we have, so with our patient-focused research center, we actually look to partner with other groups who do serve other populations. So Patient Advocate Foundation and others, Cancer Care, which deals with a largely economically underserved population. And then in the research, we also do work with market research firms to reach to populations who aren't engaged with us yet. And that's really more to make sure that we have representation in the studies and in the data that we're generating, rather than necessarily, we try to outreach to people, we can't force them to come to us. But at least we can gather data of what their unmet needs are, so we can start to address those.
Thank you. So we'll go ahead and take the last two questions, and then afterwards we'll make sure we give an opportunity to each panelist to leave us with one golden nugget that you want us to know when we leave out of this room. So the next question, please.
Yes. Hello. My name is Vincent Jordan. I'm from Jordan Wellness and Adventures. Well, first I want to thank you for the kind of information that you bring and the compassion which you bring it. My question goes more to the issues you spoke of relating to diet. I mean, all of you spoke a little bit about diet and having an effect on cancer. And I'm wondering, in the research community, what are you finding the relationship is with diet and food, particularly as it relates to something like animal proteins? Are you finding anything like that? And, well, I should be brief. That's all. Thank you.
Thank you.
So Cancer Support Community partners with AIRC. They're kind of a leader in looking at the evidence base of cancer prevention and nutrition and exercise. And they have, I think, 10 steps to healthy eating and healthy lifestyles for preventing cancer. And those do include limiting red meats, and eating a plant-based diet as much as possible, eating a colorful plant-based diet. But if you go to AIRC.org and look for their cancer prevention information, they have a wealth of information there. Cancer Support Community has partnered with them to then create information on nutrition during cancer treatment and nutrition for cancer survivors. And so if you wanted that information, that's at cancersupportcommunity.org.
Actually, it's just a comment. My name is Franchetta Payne, and my badge, I'm representing Baxter Healthcare. But if I were to remove this badge, I represent a career in healthcare, an advocate for cancer, and an 18-year survivor of colorectal cancer. And a lot has been shared today. Thank you. And congratulations to you, Dr. Wilson. We lost our youngest sister to triple-negative breast cancer. So I just commend you on the work that you're doing, and just wanted to comment and piggyback on something that has been said, 3 things. The community services or community activists, nonprofits like mine, Victory and Empowerment. When I stand up and tell a person that I'm an 18-year colon cancer survivor and what to do, yes, they listen. So that is truly important. And then one of the doctors just mentioned the Divine Nine. We're out here, we need resources, but I commend you on what you're doing. You're doing a great and mighty work. But nonprofits, community awareness, and other organizations would be an excellent means of piggybacking and getting to those persons, the barbershops, the hairdressers, the gyms, all those areas that we're meeting individuals. So thank you again for all that you do.
Thank you. So I will start with you, Richardae, first, and leave us with one takeaway message that we must need to know today.
So I'm going to take that takeaway message partly from what we just heard in your comment. I think community engagement, and I really want to say consistent community engagement. When we're thinking about advancing diversity in clinical trials, we need to have consistent community engagement and having patients really from the beginning of that trial design all the way through the completion of the trial, feedback from patients so that we can really determine how best we can increase diversity. I think that consistent community engagement is very important.
And I'm going to echo that consistent engagement and say that all of our local cancer support communities and local Gildas clubs would be more than happy to partner with any groups who can help us look at ways to get our support services to people who need them. And especially there's the opportunity with the cancer support community, Washington, D.C., that we're starting up here by 2020. We'd love to talk to leaders in the community of how can we partner with you and not reproduce your services, but add on any support services that we can.
Andrea?
Obviously echo the community engagement part in clinical trials. I think the other piece of it, though, too, is not just for clinical research and biological research, but understanding patient research to ensure that we have adequate representation in that and not study populations only in silos, but really more broadly. So a patient preference study or patient-reported outcomes or how they're accessing care to ensure that we include all in the same study so then we really can look at different subsets of that and where unmet needs might be and develop interventions or policies to address that.
I think the cancer community, because it's been working so long to come up with tools to be able to do something about cancer, hasn't as a total community thought about equity at the same time. So there's a lot to be learned, though, from other communities, other disease communities like the HIV community, diabetes, the primary care community that sees all the social determinants of health issues every single day, social justice organizations, and then going totally outside to look at where there have been successful efforts with underserved communities, whether it's in the environment or economic development. Really not staying within cancer and saying, okay, we'll start to work out these solutions, but there's so much richness in how to go forward and so much to be leveraged from other communities who have long thought about social determinants of health and also health equity issues as well.
In my practice, it has been about partnering with patients, listening to what they have to say, making sure that we're remaining engaged with the community and that the community has a strong perspective in everything that we do and that we're not only including them in the grassroots, but all the way up to the board.
Well, I want to thank each of you for being on the panel today, sharing your insights and your expertise around how we can reduce cancer disparities. I think the key take-home message that I kept hearing over and over was community engagement, keeping the patient involved across the entire spectrum of care, making sure that we're collaborating and not only with ourselves within our own sectors, but also looking outside of the box to those what we consider non-traditional partners, because we realize we can't do this work alone. And then also making making sure that we're taking the opportunity to learn from our other communities as well. So with that, I want to close out our panel today, and I want to again thank you all for participating.